Good afternoon, everyone. My name's Chris Wood. I'm a pharmacist by background, so I work 2 days a week at the Bennett Institute, analysing data and having basically a look at what's happening in terms of prescribing. My background is I'm a pharmacist, so I work a couple of days a week, or 3 days a week, in a GP practice as a prescribing pharmacist. But probably more relevant for today, because we're looking at antimicrobials, is I did work as antimicrobial specialist pharmacist for 5 years in a hospital. So I've got a bit of background in antibiotics and what's important and what we're looking at. Apologies to you that have any of you that have attended our webinars before, but I'm going to start from the beginning very briefly, just to introduce a bit about what open prescribing is and where the data comes from. When we're talking about open prescribing, we're interested in primary care prescribing data, and this is basically the main aspect of what we look at. So we talk about things like think about things like the green prescriptions. I'm sure you've all seen green prescriptions, green FP10 prescriptions before, and these basically flow through the system. So a prescription is written at a general practice, maybe by a prescriber, a GP, a pharmacist, a nurse, prescriber, any of those sorts of people, and then the prescription is sent to community pharmacy. So it goes to a community pharmacy, who then process the prescription, supply the medication, whatever's prescribed on the prescription, to the patient. As part of the flow of prescriptions, after it's all been dispensed by the pharmacy, they send them off at the end of the month to the NHS Business Services Authority, who are basically responsible for collating all the data on prescriptions, everything across England, and then paying the pharmacies accordingly. Sort of a byproduct of this, they obviously get lots and lots of information on what prescriptions have been issued. So things like who did the prescription, who dispensed the prescription, what drugs were supplied, what quantity was given, what the prices paid were and reimbursed were, and information about the patient as well, the individual patient is getting the actual item. So they end up with a huge data set every month with lots and lots and lots of detailed information in. Thankfully for us, they do publish at least some of this. So we have this data source here that is the main data source that drives open prescribing, which is the NHS BSA English prescribing data, which is basically a we call it a dispensing view of prescribing data. So basically means if a prescription has been written and then a medication has been supplied against that prescription in England, it should appear in this data set. It's obviously not everything that the NHS BSA collects, so it's all anonymised. There isn't patient-specific information, but it does give us data down to a practice level, so we can see what individual GP practices have been prescribing, what's been going on, and we can assess things from there. This data updates every month, so new data is released every single month. There is a little bit of a lag just because of all the processing kind of aspects it goes through. So we get data about 2 months from 2 months previous. So we're in November now, so we're expecting September data any day now. So it normally comes out around the 20th of the month, something like that. It's the rough date I have in my head. There's a couple of important definitions. So I think these are the only really technical definitions I'm going to go into today, and I don't think they're too complicated, but they're really important just to have in the back of your head as we go along. So one thing that we look at is items. And when we talk about items, this is the count of the number of times a medicine has been prescribed and dispensed. So it's effectively the number of prescriptions that have been written for a specific thing. So if we talk about an antibiotic, it's the number of prescriptions that have been written, say, for amoxicillin 500 milligram capsules. So it tells us about how many prescriptions have been done, but it doesn't necessarily tell us about how much has been prescribed. So what sort of duration and things like that, and what dose and things like that. Quantity is the other measure the other quantifier we use. So this is the total amount of medicine that has been prescribed. So again, to use amoxicillin as the example, say 21 of amoxicillin 500 milligram capsules would correspond to 21 capsules. It's fairly straightforward for solid dose forms, so things like tablets and capsules. It gets a little bit more complicated when you start to bring in things like, say, oral suspension. So amoxicillin suspension, the quantity is probably measured in mils rather than milligrams or any other kind of easily interpretable number. So I think the most important takeaway there is that you can't just add all quantities together for tablets, capsules, liquids, things like that, because they're just not directly comparable in that way, and there just needs to be a little bit more thought with that. So this is what the raw data, or this is a very small snapshot of what the raw data looks like. So it's a very wide data set, so there's lots and lots and lots of columns, but there's also lots and lots and lots of rows. So we think each month of data is somewhere in a couple of gigabytes of data. You would just about be able to open this in Excel, so you can open a month of full English prescribing data set in your Excel on your local computer, and you can download it. But you would really struggle to open much more than that. So if you're interested in, say, modeling something over a number of months or a number of years, you just wouldn't be able to open all these detailed data sets at one time. So this is where OpenPrescribing comes in. So OpenPrescribing is basically a tool that uses this openly published data. We take these very large CSV files and we present them in a way where we can facilitate benchmarking between, say, practices or between ICBs, and also allow further analysis, so you can drill into the data in a kind of a more user-friendly way rather than downloading all these big files or accessing the other systems. It's openly and freely available to everyone, so you don't need a login. You can share links directly to all the different things that we look at today. And we already have quite a lot of users, so we roughly think about 20,000 unique users a month that use the website. Most of these are people based in the NHS. I think a lot of you today have come from the NHS, but I know there's lots of people more widely who've joined today, which is great to see. There's lots of people based in ICBs, so integrated care boards, where things like medicines optimization teams are using the data to make sure prescribing is well managed in primary cares in their practice, in their sort of the area. It's also used by people in GP practices to make sure, you know, things are going well, that they can benchmark, say, different areas and identify areas for improvement. We also know it's used in research, so to identify maybe things that could be improved or to monitor changes. So lots and lots of different people use it, and we are very happy for everyone to use it, from, say, you know, GPs, pharmacists, ICBs, to the public as well. So we get emails from patients who've looked at their practice and found interesting things as well. So the idea is that you can use this to identify things and maybe prompt discussions or identify further action that needs to be taken. Again, a little bit more about the technicalities. So we have we make certain analytic choices when we present the data in OpenPrescribing. So you might find there's key differences between other data sets that are out there or other websites that are available. So things like EPACT or PressScript or Fingertips are some of the other ones that have lots and lots of different, say, antibiotic measures or antimicrobial prescribing measures. So I'd say you can have a look at those as well and compare. OpenPrescribing, we tend to use monthly data. So on these two charts here, we demonstrate different ways that data can be visualized. So we tend to stick with publishing data in the month that is relevant and showing very like month-on-month trends, whereas other data sources use more kind of gradual changes. You see more gradual changes, as they often use things like rolling 12-month data. So here's two examples of the different ways you can look at it. So you can see on the right, there's this 12-month rolling data where you see it's fairly kind of gently increasing and decreasing, whereas ours is always a little bit more jagged because different months, different things happen. This is quite a nice example. So this is looking at percentage of broad spectrum prescriptions, so Comox, Clav, cephalosporins, and quinolones, as a proportion of all antibiotics prescribed. So when you look at it per 12-month rolling, you can see gentle increases and decreases, whereas if you look at the monthly data, you can see things like this really sudden change that happened here. So this is December 2022, when there was big group A strep outbreak. There were lots of narrow spectrum antibiotics being prescribed, which basically brought the broad spectrum percentage down quite significantly. So it's much more difficult to see in the rolling data. So that's why we think this can be useful, but obviously both things can be useful for monitoring different things. We also use basically the open data that is published. So we don't have patient specific details. We don't have patient level data. So we're not really looking at, you know, males versus females or different age groups or things like that within OpenPrescribing. We focus on using the openly available data and using it well to demonstrate things. Our big focus is on GP data and GP practice data. So you won't find things like out-of-hours centres and urgent cares just in the measures and things that you see, just because they're not really very easily comparable between, say, a normal general practice and urgent care. They deal with very different patients and they're very different things. Just to mention one of our sister projects. So I think there's a few people that are maybe more research based than NHS based. So this is kind of one of our sister projects that we also run. So OpenSAFELY is a secure analytics platform that focuses on electronic healthcare record research data. So we work with things like System 1, TPP, and EMIS to extract data from their systems. We can look at things in a bit more detail, so down to things like patient characteristic level, patient demographic level, and prescribing, and what's happening on different levels to what OpenPrescribing shows. So if you're interested in kind of the research, the academic side of OpenSAFELY, I think Rich is going to share a couple of papers there in the chat, but we've got quite a few on antibiotics. So one that we did fairly recently, I'm sure lots of you dealt with the Group A strep outbreak and the changes that we saw in terms of antibiotic prescribing over that period in time. So now the next bit, which is our practical demonstration side of OpenPrescribing. Just before I start, I'm going to point you towards the videos that we've done previously as well, which go through some more of the in-depth stuff. So if you go to the More tab at the top and you go to How to Use, this is where we've uploaded some of our longer webinars, which focus on lots of different tools rather than just the antibiotics we're going to go to today. So when you open up the OpenPrescribing homepage, this is what you'll see. Probably the easiest, or the first place you want to start, is by going into the area and practice dashboards, and then it will probably depend on where you work as to what you want to look at. So you might want to look at your own individual GP practice, or your PCN if you're working in directly in primary care, or if you're based in an ICB, you might want to start there, or perhaps if you're looking interested in what's happening nationally, you can look at, say, regions or just across all of England entirely. So today we've had Rich has volunteered up Devon as our case study, which is quite helpful because we've got a little bit of background on what's going on there, and we can hopefully explain a little bit of what's happened as we go along as well. So click through to whatever section you want, type in the name, and then you'll click through to a dashboard page a little bit like this. It will look fairly similar for whatever sort of level you're looking at. So you're looking at GP practice, you're looking at ICB, wherever you're looking, it should look reasonably similar to this. So the buttons should all be in roughly a similar position. You might see different options at, say, an ICB than you do at a practice level. That's just down to some of the technicalities, but what we go through today should be followable whatever level you're looking at. So really here today, we're going to focus mostly on this here, which is our standard measures. Just a very, very brief overview of what our measures show. So the red line here and the red dots show what's happening at the organisation of interest. So the red line here demonstrates what's happening at the Devon ICB, sub-ICB level, and where they are at in terms of this measure. And then the blue lines show what's happening nationally. So the big, thicker dashed line shows the national median, which basically shows that 50% of GP practices in the country are below this line and 50% of GP practices in the country are above this line. And then the dotted lines show the different deciles, so 10%, 20%, 30%, 40%. So just gives you an idea of where you are and helps identify where you might be an outlier. We generally follow a principle of low is good, or low is better. So if this is creeping above the top, say the top decile, then you've got some scope to improve. There's obviously subtleties of exactly what we're looking at and what it really means. And if you're right down at the bottom, it probably means you're doing well in that, and there's not much scope to improve. It's just keeping an eye and thinking about why we're doing well. So if we click through to view all on the standard measures, you get a big long list of lots and lots of different measures. So we have somewhere about 80 measures, around 100 measures in total across the website. But this brings you to a big long list. There is definite logic in how these are presented. So they will present at the top, there'll be the measures where you are the kind of the higher up, so the biggest scope to improve, we think. And if you scroll right down to the bottom, you will see that numbers are basically at the bottom or very, very low, which means that you are doing probably pretty well in comparison to the rest of the country on this kind of aspect. And so it will obviously be different for each organisation you look at. There'll be some things you're doing well in, there'll be some things you're potentially could improve in. I think I would have a look at some of the top ones and some of the bottom ones as well, just to kind of balance things out and know that it's not all problems. It's actually there's some good things going on. So today we are really focusing on antimicrobial stewardship. So if we click through here, we can go straight through to just the measures that we've tagged here with antimicrobial stewardship as kind of the type. And today I'm just going to have a quick look through these just to kind of cover them, and then once I've got to this bottom of this, I think then we'll pause for some questions. So there's different types of measures. So we've got 10 different antimicrobial stewardship measures at the moment across the website. There's a few others that we're trying to develop at the moment, which I'll mention in a little bit. But if you've got any ideas or this gets you thinking about other things that would be good to look at, please do let us know. Maybe email us afterwards or let us know in the chat if you've got other ideas. So here we look at things like, so the first one we look at is injectable preparations for the treatment of infection. So you can see that Devon ICB is fairly high on this. So they're definitely definitely in the, we say in here, the 93rd percentile. So definitely above the national average and above what most practices in the country are doing. There's information here about why this is important, so why we think this is a useful measure to have. And then there's lots of options here about how to see things in a little bit more detail. So probably the important one here is knowing what these injectables are that are being prescribed. So if I click through, I'm going to open new tabs just to make it a little bit quicker today. So this just brings us into a bit more detail about what this measure is, and then we can scroll down and see what the individual preparations are. So interestingly here, they are all aminoglycosides, mostly gentamicin, or tobramycin, very small number of ceftriaxone and a couple of benzyl penicillin prescriptions. So speaking to Rich beforehand, we think probably a lot of this is being used nebulized, so nebulized antibiotics, and they're using the IV products for nebulization. So might be a little bit more about kind of local pathways and secondary care and primary care prescribing rather than anything particularly wrong that's happening. But that's something that sort of region would be interested in, or at least interested in understanding why that differs from everywhere else. Moving on, so we've got things like minocycline. So generally, we've started to move away from using minocycline for acne just because of some of the safety risks. So we can see over time this has been reducing. So we would expect, obviously, it to continue to reduce and reduce further. It's important to note that we do use slightly different kind of quantifiers. So whereas the antibiotic one, we're looking at items, you can see in the hover over, this is 37 items. Whereas in the minocycline, we're more interested in, or we're looking specifically at cost. So obviously, if cost changes, the price of a pack of minocycline did change, you might see a change there. It doesn't necessarily mean items are going down. Then we move on to the broad spectrum antibiotics. It's worth mentioning as well that you might not always find them in this nice order. This is partly why we've picked Devon ICB, is that they have all the different groups in the nice order, but you might find some of the broad spectrums are at the top and some of them are at the bottom, and different variations at different levels. So here we look at broad spectrum antibiotics, which I think is a big one for antimicrobial stewardship and knowing what's happening. So we have different kind of ways to visualize this and different denominators. So this first one here is looking at the common broad spectrum antibiotics in primary care. So comoxiclav, cephalosporin class, and the quinolone class as the ones we often see, and using a denominator of 1,000 patients. So basically trying to account for different practice sizes and giving us an idea of where things are. So this is always roughly run just a little bit above what the national median is, not varying too much. but it's interesting just to see it. It runs consistently around there. Again, you can break down things like individual presentations, so you can see which ones the big ones are. So there's lots and lots of comoxiclav going on, quite a lot less cefalexin, and some quinolones, so ciprofloxacin, levofloxacin's quite high up there as well in that sort of section. So again, it's worth having a look at these sorts of breakdowns. Are they as you expect? Would you expect these to be so high? Do they seem right? And then we can drill into things in a little bit more detail. So we could say maybe have a look at individual practices. So if you click through here, we will see a breakdown for every individual practice within the Devon ICB area. And again, this is ordered from highest to lowest. So if your practice is at the top, that means that they are quite a long way above, and the ones towards the bottom are a long way. They're often not even prescribing the broad spectrum. So, or some of these might have. Some of the ones when we go too far are a little bit misleading, but if we look at some of the other ones here where we see lots of prescribing data, we can see they're prescribing a fairly low number of broad spectrum antibiotics for their patient populations. Then moving on, we can look at kind of another way to quantify broad spectrum prescribing, and this is looking at the percentage of prescriptions that are broad spectrum compared to, or using the all antibiotics as a denominator, just taking out the tuberculosis drugs. Probably not much of that happening anyway in primary care, and the anti-leprotic drugs. So again, you can do similar things. So you can break down by presentation, which should be roughly the same. You can look at individual practices, which might be slightly different because we're looking at a different denominator. So you might find things move around a bit when you look at different denominators and different ways to see it. So things like that one's quite interesting. So we can see this GP surgery was fairly low back in 2020, 2021, and has over time gone up in the amount of broad spectrum prescriptions they prescribe every month. So roughly around about 6 or 7 prescriptions a month, up to now about 15, 18. So there's definite trends to be seen there. I'm sure if we scroll down, we will see trends the opposite way, hopefully. Scroll down far enough. Say this one here. So you can see it's quite a lot of volatility, but you'll see generally it's all on a downward trend. So there's probably good things going on there in terms of reviewing and being cautious about prescribing broad spectrum antibiotics. We also look at obviously just total volume of antibiotic prescribing. So this is number of prescriptions for all antibacterial drugs. Again, to make sure just generally antibiotics not being overprescribed. Again, you can break it down into similar things. So you can see what antibiotics have been prescribed. Doxycycline has the most number of items, so the most number of prescriptions. So lots of information there. Should be closing these tabs as I go along. Then we've got things like important safety indicators. So obviously fluoroquinolones with lots of different MHRA alerts about potentially disabling or long-lasting side effects, adverse reactions to them. So only really used where there's not much else that can be used. So again, we can see that's on a downward trend. You can click through and see which practices, say, have changed on that. Could also have a look in broader details. So we can use things like view on the Analyse page, and I'll cover the Analyse page in a little bit more detail later on, but you can see, say, what's happening at different ICBs or different sub-ICBs across the country. And if we're looking at Devon, we can see exactly where they sit in terms of the kind of the national trend. So they're down here, so probably in the lower third. So that's kind of a useful other way to look at it. So what I would say is just if you find a measure you're interested in or want to focus on, have a look at all these different options down the side, because there's lots more information you can find there. Then we look at durations of antibiotics. So there's been lots and lots of focus, definitely more recently, on durations of antibiotics. So one of the ones that's been looked at for a lot longer is 3-day courses of uncomplicated UTIs in females. So this is a measure just looking at short courses of UTI antibiotics, so things like pivamecilidam, trimethoprim, nitrofurantoin, and fosfomycin. and how many prescriptions are for 3 days versus how many total prescriptions are prescribed for these medications. And we then also look at other antibiotics. So amoxicillin and doxycycline are the two other ones that have been focused on at the moment. So we can see there's some really big changes that have happened here. So Devon has come down very suddenly. So there's been some work that's gone on in the Devon area. I think this is where I can show you the what we call our improvement radar here as well. So there's this option here, see which sub-ICBs have improved most on this measure. If I can get to it here. So this takes you to another page where we basically identify the organisations that have shown significant change and sudden change. So it helps you identify perhaps where an organisation has made some changes or made something big that has had a reasonable amount of impact. So Devon here is showing there as this big trend change. You can see, yeah, so amoxicillin, sudden change in April 22, May 2022. And doxycycline, we can see they've also had fairly big rapid changes. So a little bit later, but May 2023, again, they've had a big sudden change here that's brought them down from 29th percentile down to the 7th percentile. So big changes. And then the last one we have on here is our very long-standing, I think, trimethoprim as a percentage of prescribing of nitrofurantoin and trimethoprim. So this was when there was a big kind of push towards using nitrofurantoin as the first-line antibiotic for UTIs, just because there was quite a lot of resistance developing to trimethoprim. You can see, I think if we went further back, you would see this probably started a lot higher and has come down a long way. But it's showing that it is being maintained that nitrofurantoin is one of the drugs of first use over trimethoprim, which is good to see. So those are the measures that we have pre-built on antibiotics. There's lots more that you can kind of explore as well on the website. Just before I move past that, probably just worth me mentioning. So if you are looking at your measures and looking at what's going on in your practice, it's worth also signing up for our email updates as well. So if you scroll down, there's this section here saying sign up for our alerts or updates. Basically means every month, so every time we update the data in OpenPrescribing, we'll send you an email. It's a little bit outdated, but it looks a little bit like this. So we tell you what's changing within your practice or your organisation, what's getting better, what's getting worse, what's an outlier. And it's just a useful prompt to have another look at the website and see what's happening and see what's changed with the latest import of data. Right, okay, so I was moving onwards. So we'll look at some of the other tools as well that we have in OpenPrescribing. So kind of the interesting ones from an antimicrobial perspective. So we've got this one here. So we've got all BNF sections and the trends that we see. I think generally today we're probably more interested in items rather than spend. And then we can scroll down and we can look at, say, all antibacterials. So we can look at what the trends are in terms of all antibacterials. I'm going to switch back to items again. So we can see that there is some variation over time in terms of antibacterial number of items. This again, I think, is what I mentioned, December 2022, which was when there was lots and lots of prescriptions for group A strep. So that's that sudden increase there, and that's why that's a slight outlier. Again, you can see sort of seasonal changes as well. So around December, January, there was often peaks, more chest infections, respiratory tract infections, things like that going around probably. You can have a look at, say, different groups. So again, penicillin was kind of the first line antibiotic for group A strep. So we would expect to see lots more items for that as well. So you can have a click around and have a look at the different sections and look at different trends over time if that's what you're interested in. You can also, say, look at different chemicals as well, trends for different chemicals. So this is one Rich likes to look at, so flucloxacillin. Again, you can see trends, say, over months for just flucloxacillin in general, and you can see there's always these summer peaks. So the opposite of the general antibiotic trend is peaks around the summer, which we think is possibly things like insect bites, treatments for insect bites, which tend not to happen in December, January as much. So you can see lots of different trends and lots of different things happening in the data if you dig around. We'll also show you the Analyse page and how you can use this to kind of identify things in a bit more detail. So Analyse page is where you can do your own analysis and you can dig out whatever you want. So gives you this form, which is a pretty blank page for you to do what you think and what you're interested in. I've got a couple that we've had a look at a little bit earlier today. So when we're thinking about UTI treatment, so fosfomycin and pivmecillinam are a couple of like the second line options. So something I've seen within the PCNI work is that certain GPs are really familiar with these antibiotics, really willing to prescribe these antibiotics, and certain GPs have never prescribed them before and feel a bit unfamiliar and I think a little bit concerned or a little bit less willing to prescribe them because they've just not done them before. So we can compare, say, how often these have been prescribed versus, say, we can either look at, say, the broad spectrum antibiotics, cephalosporins, and quinolones. And we can also add in the fosfomycin, so we get an idea. So that gives us a kind of a rough idea of how often these second line UTI drugs are being prescribed compared to some of these broad spectrum antibiotics, which are sometimes used for UTIs as kind of second, third line options. So people that are, where you can't use nitrofurantoin, you can't use trimethoprim. People that have that kind of gap in their knowledge about pivmecillinam and fosfomycin might start to reach for some of the broad spectrum antibiotics. So here we can see there's quite a big difference across the country. So this is like Blackpool prescribing very little, just 17 items of fosfomycin and pivmecillinam a month, whereas places like Somerset are prescribing much more, 1,690. So that's a huge difference across the country of what's going on there. Things like the map can show this even better. So you'll see that there's a couple of kind of hotspots. So Somerset and this one here, Thameside and Glossop have fairly high proportions of prescribing of these. We can clear it and we can look at, say, things like total list size instead. So maybe the regions are slightly different sizes. Again, you see it's fairly similar. So these regions are prescribing more per the number of patients. Probably just they're more familiar with these things, but I would say, this is my opinion, I would say this is probably good practice going on, that they're using these antibiotics to spare the use of broad spectrum prescribing. So say if you're in an area where this is very low, this might be something to have a look at. Are your GPs familiar with these antibiotics? Is there a reason why they're not prescribing these? So these are some of the things some of the examples of what you can do with the data. You can look at it at different levels as well. So we could look at it, say, an NHS England region instead. Let's take a little time to load. Probably just a bit skewed by the different ICBs in there. But you can even look at it down to practice level. If we load this one, you can see here. So different practices doing different things. We'll do another one quickly, which is one Rich suggested again. So there is quite a lot of levofloxacin prescribing going on in the Devon region. Quinolones. So we're interested to know, is this just the Devon region, or so we saw it in that list. So is it just the Devon region, or is it something that happens nationally? So if you put this in, you look at sub-ICB locations, you can see yes. So it is predominantly the Devon region that prescribe lots of levofloxacin. The other one is the Nottingham region. So both prescribe quite high numbers. And then maybe you're interested in seeing, is this something that happens just across the ICB, or is it certain practices? So we can dig into that in a little bit more detail. We can see actually there's certain hotspots, so around this area here, so the southwest side, so Plymouth area, there's lots more kind of darker red dots that are prescribing more levofloxacin. And there's areas, I mean, lots of these are not prescribing quinolones at all, which is possibly quite good. Or they're not prescribing levofloxacin, they're prescribing other quinolones. So obviously it's a bit about what the local guidelines are and whether that's appropriate or whether that's what they want. I think levofloxacin is up there in the local guidelines, but there is quite a big difference between different areas within the ICB. So just some variation that's worth knowing about. It could be good, it could be bad, it could be not of consequence, but that's how you can use the data and use our tools to kind of dig through into things. I think those are the main tools anyway in terms of antimicrobials. Have a look at our trends as well, so you can see if you're interested in things like price changes. You can use things like our drug tariff tracker. You can see our blog as well. So if you click through to our blog, we write lots about what we're looking at. So it's not just antibiotics we cover on OpenPrescribing. Obviously, it's all the other things medication related. Antibiotics is my area that I'm interested in, but there's lots of different things we look at. So if we find something interesting or we change a measure, we will write about it in our blog. You can also sign up for our newsletter. So if you go through to stay in touch, you can put your details in there, and then we will send you our newsletter as well. So as we write updates, or as we change things, you can sign up to our newsletter, or as we launch new measures, say. So I would encourage lots of you to sign up to our newsletter and our alerts today. I think is probably one of the other things you could do other than looking at the measures. Just to briefly show you, so I mentioned things like the Analyse page, so we can use that to start looking at things. Then if you do have ideas about what's important and what we can look at, do email us, because we can start to preview things as well. So we can start to look at things that we think might be important and try and see what's happening and see how useful it would be to build measures permanently into the website. So there's a few here we've started to look at, and we're still working out kind of the fine details, but we're starting to build a measure looking at longer courses and shorter courses of flucloxacillin. Identifying where people are prescribed long-term antibiotics, so long prescriptions of antibiotics that are commonly used for UTI prophylaxis, or looking at things like methenamine prescribing as well. So using methenamine as kind of an alternative to antibiotics for UTI prophylaxis. So there's lots we can start to build, and I would say if you've got any ideas at all that come up, I know there's lots of specialists here today, and lots of people with lots of different backgrounds. So if you start looking at the data and you think there's something interesting, do email us, because it's fairly easy for us to put together some previews and start looking at whether this worth sharing with everyone and whether everyone can learn something from this. So thank you everyone for joining us today for this webinar. So antimicrobial stewardship special just for World Antibiotic Awareness Week. Do sign up for our emails, do sign up for our newsletters, and we hope to see you again soon. Thank you. Bye.